Today I'm bringing to you a case, a 21-year-old cricketer. He says he has pain at the medial side of the elbow, forearm and wrist when bowling, and this pain exaggerates itself. It is a sharp pain that comes through during the deceleration and the follow-through phase. This was his x-ray. When we look at the x-ray, it looks fine, except for the fact that maybe the radial epicondyle or the lateral epicondyle of the humerus is a bit hypoplastic and underdeveloped compared to the large medial epicondyle. Other than that, everything looked normal. The fat planes around the elbow are normal. The radial head did not show any injury. The coronoid process tip did not show any fracture. We were looking at a near normal elbow x-ray. However, we did do a carrying angle for this patient, so the humeral and the ulnar axes were measured together, bisecting the angle, which was about 17 degrees in this patient, which qualifies for cubitus valgus. Patients who have cubitus valgus tend to have traction-related neuropathy of the ulnar nerve. So we thought we'd be looking into that. We could also be looking at something called the vastus extension overload, in which we would see UCL or MCL injuries. This was his MRI going from posterior to anterior. This is the coronal PDFS, proton density fat saturated image. We're looking at the olecranon process here, which more or less looks normal. There are no large spurs, there are no erosions. The olecranon fossa fat also does not show any inflammation. And as we go more anteriorly, we start to see the UCL or the ulnar collateral ligament. The deepest layer being the capsule, the superficial most layer being the aponeurosis of the flexor digitorum. These are the fibers of the ulnar collateral ligament. The anterior bundle is the major stabilizer of the medial joint line. The posterior and transverse bundles have limited role. We see how the ligament attaches itself a bit more spread out at the humeral margin, and it becomes a definite cord-like structure when it terminates at the sublime tubercle of the ulna. We're also seeing the common flexor origin here from the medial epicondyle. And what we're looking at the radial side is a bit of an enlarged synovial plica here, the radiosynovial fold. And even though I did not see too much inflammation, I did feel like there was some bony remodeling because of the enlarged plica. He did have some changes at the undersurface of the common extensor origin, namely this is the region of the extensor carpi radialis brevis, and this heterogeneity and an intermediate high signal would be concerning for a tennis elbow, but the patient did not have radial sided pain. His pain was on the medial side, at the medial side of the forearm and reaching up to the wrist. The cartilage also looked normal. That is our lateral epicondylosis, if that's what you would call it, but the patient was not symptomatic of it. And this is a normal occurrence. We see that a lot. This is the axial T1 weighted MRI image where the fat is not suppressed and fluid signals are dark. The muscle is iso-intense. This is the anterior muscle group, the brachioradialis, the brachialis, and the biceps. We'll also see the common flexors coming up here. This is the triceps muscle. The long and the lateral head fuse to form a tendon, and the medial head usually has a muscular attachment upon the olecranon process of the ulna. As we ride downwards caudally, we'll start to see a normal appearing olecranon fat pad, and just where the medial head attaches upon the ulna, below that is another muscle, which is the anconeus. This is the flexor pronator mass, and this is the anconeus, and we've already seen these muscles. That's the brachial vessels and the median nerve. And here what we see in the retroepicondylar region is the ulnar nerve. Note how this groove is a bit shallow. Normally we would see a small trough here, but there isn't one. Also note that on the roof of the cubital tunnel is a small muscle, something that should not be seen. We only see a thin ligament called the ligament of Osborne, which is a continuation of the posterior bundle of the UCL, and this is the transverse bundle, which is the floor of the cubital tunnel. So the cubital tunnel should just have a thick band-like structure, which is the ligament of Osborne at the roof of the tunnel, and no muscle should be seen in this interval. As we go a bit caudally, we'll start to see that there's a muscle taking off from here. The transverse bundle looks a bit more striated. The ulnar nerve can be oblong or flat or quadrangular, that's all right. And the fat around it is preserved. And as we go a little more cranially, we'll see that there is the origin of the ulnar and the humeral head of the flexor carpi ulnaris, through which the ulnar nerve passes under the arcuate ligament and then traverses anteriorly. This is the annular ligament, the proximal radioulnar articulation, and just below that would be the attachment of the lateral ulnar collateral ligament. So while the Anconeus is a normal appearance on the MR at the lateral aspect of the elbow, just beneath the attachment of the medial head of the triceps upon the olecranon, the Anconeus Epitrochlearis, which is seen at the roof of the cubital tunnel at the posteromedial aspect of the elbow, is an anomalous or an accessory muscle which is present in about 3 to 28% of the population. Having said that, this muscle is not symptomatic in any way to most people, but for players and especially bowlers with overuse injuries, this can be a problem and they could be injuring their ulnar nerve every time they throw. Look at the PDFS axial image. This is the distal humerus. As we roll downwards again, we're looking at an ulnar nerve here which is of a higher signal than that of the median nerve, medial to the brachial vessels. So you'll see that it's slightly of a higher signal and stays so. This is the anomalous Anconeus Epitrochlearis. Again, the ulnar nerve seems to be of a slightly higher signal than its counterpart, the median nerve. As we go downwards, now you'll start to see that the ulnar nerve is almost the same signal as the median nerve and becomes normal at the level of the arcuate ligament and the flexor carpi ulnaris. So these were the findings. Even though they were subtle, the patient was having this symptom since 1.5 years. It was debilitating his play, and EMG and NCV studies were done which also showed ulnar neuritis related pain, and this is the feature of an Anconeus Epitrochlearis. This is how it should normally look, with just a thin or a thick band of the ligament and no muscle on the roof of the cubital tunnel. So this patient went in for surgery. The muscle was identified and it was resected, and the patient now on 1.5 year follow-up is symptom free. Thank you very much.